I welcome you all again to this Clinical Neurology Forum. This time I am grateful to the team from Savita Medical College under Professor Vinod Khanna, who is the head of the department and Professor of Neurology. And his team is presenting cases today for discussion. And I am passing it on to our friend C.T. Suresh, who is the professor and head of the Department of Neurology at Indira Gandhi Medical College, Pondicherry. Over to you, Suresh. Please continue.
Good morning, sir. Sir, we are about to start the 54th webinar on Feb 22, 2026. I'm happy to invite Professor and Head of the Department, Professor S. Vinod Khanna, who is I'm giving a short introduction of him. He's a gold medalist from Tanjore Medical College at MD General Medicine, and he has 12 international publications and papers, and he has 4 chapters in fields of neurology and is co-author in the Handbook of Neurodrugs, which was written in 2024. And we have 2 presentations. 2 presentations will be done by Dr. Anush and 1 presentation by Dr. Sharad Kumar. I hand over this to Dr. Vinod Khanna to conduct the proceedings further.
Continue, Suresh. You invite Anush and ask him to present.
Yes, sir. I'm inviting Dr. Anush to present the first case, the lipid lock. It's an interesting and seems to be a fascinating title. Over to you, Dr. Anush.
Good morning, respected faculties.
Yes, sir. Are you on?
Anush?
Inge kana better.
Anush?
Sir, good morning. Sir, is audible, sir?
Yes, sir. You are audible.
Sir,
Good
morning, good morning, respected faculties. Myself, Dr. Anush, final year resident from Savita Medical Hospital. Today I am presenting 2 cases. First one is the lipid lock, and the second one is the triple threat. So here I am proceeding with the case, the lipid lock.
Yeah, you can unlock the lipid, but வந்து கொஞ்சம் எக்கோ இருக்கு. மைக் வந்து கொஞ்சம் அட்ஜஸ்ட் பண்ணுங்க. நீங்க பேசுறது கொஞ்சம் எக்கோ வருது. ஆடியோ சரியா இல்ல.
Yeah.
Is it better, sir? No?
Yeah, better. Try, continue, we'll see.
Continue.
Okay, sir. Thank you.
கனி என்ன ப்ராப்ளம் உங்களுக்கு?
Screen sharing is it coming, sir?
Sir, screen is coming.
Yes, sir. Correct.
Yeah.
Right. Okay.
Yeah.
Why it is not coming, sir?
Yeah. You can start, Anush.
Here is the lipid lock. So history: 38-year-old female born out of a non-consanguineous parentage from Chennai, presented with weakness of all 4 limbs for the past 2 years.
Slide
normal. She initially
Anush, slide display ஆகல.
Sir,
slide display ஆகல இப்ப.
The first slide came, second slide is not came actually.
The lipid lock is locked.
You have to take the IED, sir. It's a lip lock maybe.
முதல்ல அந்த ஸ்லைட் வந்தது இப்போ காணோம்.
Sir, is it
First slide was there, Anush. After that
அந்த பேஷண்ட் போட்டோவோட வந்து
it came.
டைட்டில் ஸ்லைட்லாம் வருது இப்போதைக்கு. We are seeing only our title slide. You move to the second slide.
உட்காந்து படி ஃபர்ஸ்ட். இந்த லெசனை வாய் விட்டு படிப்பா. 2 லெசனையும் வாய் விட்டு படிச்சுட்டு அதுக்கப்புறம் எம்சிக்யூஸ் பாரு.
Sir, screen now is visible, sir.
Yes, now it's visible.
Start, Anush.
இப்ப திருப்பி போயிடுத்துப்பா.
Sir, you're in mute mode, sir. Please unmute yourself, sir.
I unmuted. அதனால தான் பேச முடியுது. இப்ப ஸ்லைடு விசிபிளா இல்ல. Anush, are you there? கனி, அனுஷையும் காணும், அவர் ஸ்லைடையும் காணும்.
அதான் சார் அவங்க மியூட் என்ன சொல்றோம், பட் அன்மியூட் ஆகல சார். அவங்க அன்மியூட்
யார்
பண்ணா அவங்க பேசணும்.
அவர் அன்மியூட்
ஆமா
பண்ணலையா? இல்லைன்னா
அவங்க
நீங்களே
அன்மியூட் பண்ணணும் சார்.
நீங்களே அவரு தோண்டி அன்மியூட் பண்ணிவிடுங்க. இல்ல எல்லாத்தையும் அன்மியூட் பண்ணிடுங்க, அப்புறமா மியூட் பண்ணிக்கலாம்.
ஓகே சார்.
We'll tell them no interference. Satish, are you there, Satish?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
என்ன ப்ராப்ளம்? ஏன் வர மாட்டேங்குது? இப்ப நீங்க வரீங்க, ஸ்லைடும் வர மாட்டேங்குது, அனுஷம் வர மாட்டேங்கிறாரு.
டெக்னிக்கல் இஷ்யூ சார். வெளியே போயிட்டு திருப்பி உள்ள ஜாயின் பண்றாரு சார். நிர்மல் ஹியர் சார்.
Okay.
He's going out and joining again, sir. Some technical issue, sir. He will join now, sir.
Okay. Thank you.
Shall we ask second speaker to present a case?
யார் ரெடியா இருக்காங்களோ பிரசன்ட் பண்ணட்டும்.
We can ask Dr. Sharath, sir. I think Dr. Sharath has to present. I think he's online, sir. We can ask him. Dr. Sharath, can you present?
Yes, sir. We'll ask him to present now, sir. Yes, sir. They're actually together only, sir. So some signal issues, sir. We'll ask him to present now, sir. Yes, sir.
Whoever is ready, let them present.
Anush joined.
Anush has come.
Sir, sorry for the inconvenience, sir. Just 1 minute. Sir, is it visible now, sir?
No.
இன்னும் வரல, slide share வரல.
Slide வரல. Share the slide. Yes.
Yes, now the slide is visible.
Go to the next slide. It's coming. Start.
So first case, Deepak, sir. History: a 30-year-old female born out of non-consanguineous parentage from Chennai, presented with views of past 2 years. 2 years ago, she was apparently normal. She initially noticed that she had difficulty in the getting up starting position, needed support to get up. She also
Proceed, Anush.
She also had difficulty in climbing. She also had difficulty in climbing stairs. Weakness was more when she was climbing up. But knees 8 times. She had difficulty in gripping of footwear, and she also noted her lower limbs were flat. She had difficulty reaching objects to her head, but was able to mix food and button her dress. Overall, she felt her left side was more weaker than right. No difficulty in holding head up, and no history of dropped head. No difficulty in rolling over in bed. No double vision, dysphagia,
Anush,
dysphonia,
slide move
nasal
ஆகல.
degeneration, dysarthria.
Anush, your slide is not moving.
Yeah.
இப்போ okay.
Sir. Yes, sir. She also noted her lower limbs were flail. She had difficulty in reaching objects above her head, but was able to mix the food and button her dress. Overall, she felt her left side was more weaker than right. No difficulty in holding head up, and no history of dropped head. No difficulty in rolling over in bed. No double vision, dysphagia, dysphonia, nasal regurgitation, and dysarthria. No facial lag, able to close eyes tight, and there is no leaking of water while drinking. And there is no diurnal variation, muscle twitchings, muscle cramps, and myalgia, and colloidal urine or second wind phenomena. And there is no history of arthralgia, skin rash, palpitations, dyspnea, or swelling. She denies her sensory symptoms, and there is no bladder and bowel symptoms present. So, summary: 32-year-old female. A 32-year-old female with a negative family history presented with chronic, insidious, progressive neurological illness for the past 2 years in the form of asymmetrical left more than right, flaccid quadriplasis involving proximal and distal muscles of the lower limb and only proximal muscles of the upper limb, sparing distal muscles of upper limb without autonomic or extranodal involvement. The differential diagnosis: muzzle versus antenna horn cell. Probable diagnosis are
You're not audible.
Anush.
You're not audible and your screen also has stopped sharing.
Not audible nor visible.
Thanks.
The technical team help பண்ணுதா இல்லையா?
Sir,
Please.
Now it's visible.
correct.
Now it's
You were in the summary slide ல இருந்தப்ப அதுக்கப்புறம் diagnosis போனேன்.
Summary: a 32-year-old female with negative family history presented with chronic insidious
Yeah, you've gone through all this. ஏதோ comorbidities
Yes,
உண்டா? Any comorbidities?
No, sir, no. Sir, middle-aged female without any comorbidities, and there is non-consanguineous
Okay.
parentage, sir.
Okay, continue.
First, two years before she was completely normal. She was gradually progressing proximal muscle
continue with your
weakness in the
differential
lower limb, followed. Okay, sir.
Continue with the
Limbogital muscle dystrophy and facioscapular humeral dystrophy. Progressive probable diagnosis: progressive muscular atrophy or adult onset spinal muscular atrophy, which is may present with pseudomyopathic pattern, and treatable etiologies are motor CIDP. Examination: general examination was unremarkable. No contractures or rashes. Single breath count was 24, and the respiratory rate was 14 per minute, and vitals were stable. Higher mental functional examination was normal. And there is no cranial nerve involvement. There is no facial weakness. There is no tongue wasting and fasciculations or weakness. Wasting noted in bilateral deltoid, calf muscles, and intrascapular region, which is asymmetrical. Left-sided scapular winging present, and exaggerated lumbar lordosis was present. Hypotonia noted in all four limbs. Then there is no fasciculations. Power examination: there is supraspinatus right side was 3/5 and left side was 2/5, and deltoid right side 3/5 and left side was 2/5. Trapezius and sternocleidomastoid was normal on both sides. Rhomboids and serratus anterior infraspinatus muscles tested weak on both sides. Biceps and triceps was 4- on the right side, and left side it was 3/5, and supinator and pronator teres was weak on both sides. Brachioradialis 4- in the right side and 3/5 in the left side. Intrinsic muscle examination was normal in the upper limbs. In lower limbs, patient's hip flexors and abductors was weak on both sides. Right side it is 4/5 and left side is 4-5. And hip extensors and adductors were right side 3/5 and left side was 2/5. Knee flexors, right side 3/5, left side 2/5, and knee extensor, right side 3/5 and power left side 2/5. Ankle dorsiflexion and plantar flexion also weak on right side and left side, and left side is more than right. Inversion eversion and toe grip was weak on both lower limbs. Neck flexors and extensors were normal, and there is no Beaverson and there is no extensor digital brevis hypertrophy. Reflexes, superficial reflexes was present, and bilateral plantar was mute, and triceps were normal on both sides, and brachioradialis was decreased and diminished on both sides. Knee jerk 2+ and ankle jerk 1+ present bilaterally, and patient was having waddling gait, and then the rest of the neuro examination was unremarkable. So after examination, a 38-year-old female, progressive, pure motor, asymmetrical, left more than right, limb girdle pattern of weakness with no fasciculations or differential type of weakness, and spared higher mental functions and cranial nerves and sensory and cerebellar and autonomic and extrapyramidal systems.
1 minute. Why do you say there is no
Okay,
differential type of weakness?
It's a patient. There is no much of wasting, sir. Patient having more weakness than the wastings.
Oh, what you are trying to say is there is no wasting proportional to the weakness. That's what you are saying.
Yes, sir. Yes, sir.
Differential type of weakness, it amounts that certain muscles are not, uniformly it is weak and Ramari, Here it is not so. It's a differential weakness. Only thing is there's no wasting.
Yes, sir. There is improportionate weakness compared to the wasting, sir.
Correct. But the weakness itself is not symmetric and it is not uniform.
Yes, sir.
Certain muscles are more involved than the others.
Yes, sir.
So there is a differential type of weakness. Only thing is what you wanted to say is there is no wasting.
Yes, sir.
Right. Continue.
Okay. So here differential diagnosis based on the history was limb girdle muscular dystrophies or facioscapular humeral dystrophies. So furtherly, we planned for CPK, EMG, nerve conduction study, and ECG and echo with whole exome sequencing. So in the rotational biochemistry examination, blood count, LFTs and RFTs was within normal limits, and the CPK came to be high. It was 804. And nerve conduction studies suggestive of CMAP reduction in both upper limbs and lower limbs, and the snaps were preserved. And EMG was consistent with myopathic pattern, and EMG was suggestive of short duration of MUAPs, and which is low amplitude and with early recruitment. And echo was normal study. There is no regional one motion abnormality. EF was normal, and patient was having grade 1 LV dysfunction without any pulmonary arterial hypertension. The ECG also within normal limits. So then we proceeded with whole exome sequencing, which came to be positive for PNPLA2 mutation, which is homozygous gene mutation causing neutral lipid storage disorder with myopathy detected. Retrospectively, an interesting finding in peripheral smear called Jordan's anomaly noted in the literature. Then we proceeded with the peripheral smear, which came on right beams of stain. It was suggesting of lipid droplets in the peripheral smear along with the neutrophils. And on pseudo black stain, it was able to demonstrate neutral lipid granules. So, which is classical of Jordan's anomaly, which is indicative of neutral lipid storage disorder, which is suggestive of lipid vacuoles in the neutrophils and monophiles. It is often detectable even before clinical weakness. Key highlights about neutral lipid storage disorders are: it is a rare autosomal recessive lipid metabolism disorder characterized by accumulation of neutral triglycerides, storage in the skeletal muscle, heart, liver, and leukocytes. It is a multisystem lipid storage myopathy. The main genetic subtypes are neutral lipid storage disorder with myopathic predominant pattern and neutral lipid storage disorder with ichthyosis predominant pattern. It's also called Chennai syndrome. If in a neutral lipid storage disorder with myopathic pattern, mutation will be PNPLA2, and it is a defect in the adipose triglyceride lipase gene mutation. Which neutral lipid storage disorder with ichthyosis predominant is shows the mutation in ABHD5, which is co-activator of ATGL. These patients will prominently present with skin and hepatic involvement. The two clinical presentations is heterogeneous, typically featuring adult onset, progressive, and often asymmetrical proximal myopathy, frequently accompanied by hypercemia. Cardiac involvement occurs in up to 40% of the cases, necessitating routine screening. Reports of genetically confirmed neutral lipid storage disorder with myopathic pattern remain scarce in India. Phenotype slowly progressive lipid storage myopathy, typically neuromuscular presentation with adult onset proximal muscle weakness, which is either lembogirdle pattern or scapuloperoneal pattern. Patient with exercise intolerance and myalgia, often mistaken for muscular dystrophies. Cardiac involvement is a major prognostic determinant, especially in the PNPLA2 related neutral lipid storage disorder with myopathic pattern. Hypertrophic or dilated cardiomyopathy is common with some patients present with arrhythmias. Heart failure can be dominant, can dominate prognosis. Neurologists must screen early with ECG and plus echo and cardiac monitoring. Creatine kinase is usually elevated with mild to moderate CK elevation is possible, often 2 to 10 times. With persistent CK hypercemia may precede weakness. Muscle biopsy shows lipid vacuolar myopathy, key histopathology suggestive of vacuolated fibers. On oil red and Sudan staining shows neutral lipid droplets. And there is no primary inflammatory infiltrate and may mimic metabolic myopathies. Systemic clues help distinguish subtypes like PNPLA2 with severe myopathy pattern with cardiomyopathy with minimal skin involvement, ABHD5 mutation, Chennai syndrome with the congenital ichthyosis and hepatomegaly and fatty liver. Developmental delay is possible. Confirmed diagnosis via genetics and lipid demonstration. Workups include peripheral smear for Jordan's anomaly and muscle MRI and muscle biopsy with lipid stains. And there is definitive diagnosis with PNPLA2 or ABHD5 sequences. Treatment and management of the neutral lipid storage disorders are under therapeutic trials. There is no effective treatment has been clearly demonstrated. Early diagnosis is important for timely management and future therapeutic trials. Benzafibrate has been proposed but lacks clear clinical benefits. Dietary modification, diet-rich carbohydrate might help decreasing the symptoms, and engine replacement remains underexplored. Clinical management, early diagnosis is crucial for optimal patient management, genetic counseling, and participation in future therapeutic trials, even though no clearly effective treatment currently exists. Conclusion is neutral lipid storage disorders is a rare but highly recognizable lipid storage myopathy where a simple peripheral smear, Jordan's anomaly, can provide the diagnosis. Consider neutral lipid storage disorder myopathy in the differential diagnosis of asymmetric progressive myopathy with elevated CK levels, creatine kinase levels, with patients sometimes present with cardiac involvement, which is the key determinant of outcome. Thank you.
A few months ago, Anush,
Sir.
The Chengalpet Medical College team presented a similar case with Jordan's anomaly, and they also stressed the peripheral smear established the diagnosis. So a case had been presented last year, I think 6 months ago, maybe some of those who have been following will know. This was presented from Chengalpet Medical College. Unfortunately, Balaji is not here in the participants. Otherwise, I would have called him. So they had presented. I want to know, what is neutral lipid? What do you mean by neutral lipid?
So the lipid deposition forms in the lipid deposition in the muscle, sir.
Correct. Why do you call it neutral? Why do you call it neutral lipid? What does it mean?
It is mostly predominantly accumulates in the WBC cells, sir. The neutrophils we'll see in the staining, sir.
Sir, sorry to interrupt, sir.
Yes,
Sir, these
Satish.
are triglycerides. Sir, Satish, sir, this is Satish, sir.
Yeah, I know. I
Sir, these
wanted
are
to call you.
these are triglycerides which do not have any charge, sir. They're not hydrophobic or hydrophilic, sir. They don't have any repelling or attracting properties, sir. Triglycerides.
So these are deposits of triglycerides, huh?
Yes, sir. Yes, sir. Triglyceride. Yes, sir. Yes, sir. They are neutral, sir. They don't have hydrophobic or hydrophilic, sir. Generally, lipids are hydrophobic, sir. Here they are neutral, sir.
Sorry, do they reflect in the blood also with hypertriglyceridemia?
No, sir. No, sir. They don't have hypertriglyceridemia, sir. It is the abnormal deposition only in the tissues, sir. Like RBCs, muscles, and in tissues, sir. In liver, like that, they deposit.
Yeah, right, fine. It's a genetic abnormality. So what is the relation between triglyceride and muscle?
Sir, metabolism, sir. Sometimes the muscles may use fatty acids or something for the long endurance exercises. They don't use glucose, sir. For short duration, they use glycogen, but long duration they need fatty acids, sir.
And in the fatty acids, it's triglyceride which is used more, huh?
Illa, sir. Fatty acids derived from various lipid sources, sir. Triglyceride could be one of the sources.
Fatty acids are derived from triglycerides during the exercises and fasting, sir, predominantly.
Okay.
Vinod, sir. Vinod speaking, sir.
Yeah, I can hear you. I can see you also.
Anush.
Yes, allegation and CTS.
Yeah, you just forget about the genetic analysis.
Okay, sir.
Based on the clinical examination, what's your provisional diagnosis?
Based on clinical examination, patient middle-aged female without any consanguinity, and there is no comorbidity, is not on any medication. She presented with first difficulty in getting up and difficulty in climbing stairs, which indicates.
Adela right, Anush. What
diagnosis?
Is
diagnosis. Tell the diagnosis.
Examiner is asking you what is your diagnosis.
Sir, it is limb-girdle pattern of muscle weakness, sir.
Yeah, so my thinking is limb-girdle muscular dystrophy, probably calpainopathy, because of the age of onset and extensor adductor weakness.
Yes, sir.
But in such a situation, I will ask only for a targeted panel for limb-girdle muscular dystrophy. Why you asked the whole exam sequencing? Any idea behind this?
Sir, there was asymmetric involvement, sir. Scapula was also weak, sir. So along with the limb girdle pattern, FSST also was a primary differential, sir. So we actually wanted to do genetics for FSST specifically, but labs offering FSST is very costly, sir. It's actually more than 50,000-60,000. So we thought, since our DDs were very broad, we thought we'll go with whole exome first, sir.
Oh, right.
Sir, one more.
Scapuloperoneal weakness, sir. Scapula was involved. I agree, sir. Calpainopathy is a DD also, but patient had calf wasting, which is more feature of dysferlinopathy than calpainopathy. The primary clinical DD was FSST versus a limb girdle pattern of muscle weak, limb girdle dystrophy, sir. So since DDs were a little bit broad, so we went for genetic whole exome, sir.
The maximal weakness was the dorsiflexus of the ankle.
Dorsiflexus, but patient also had calf wasting, sir.
It was a distal muscle which was maximally affected.
Yes, sir. Scapula and peroneal muscle, sir. So scapuloperoneal pattern of weakness, sir.
Humeral also.
Yes, sir.
Scapulo-humeral peroneal.
Yes, sir. And asymmetry was also clearly evident on examination as per ST, sir. So we are more skewing towards FSST based on the clinical picture, sir.
Right, sir. CTS, silent target CTS.
Yes, sir. Scapular ringing can come in calpainopathy also, sir. That's one point. And serum CPK was not very high for a dysferlinopathy.
800 and not.
Yes, sir. It was not very high for a dysferlinopathy. And the third thing I wanted to ask is whether the pattern had any hip abductor weakness, any signs like valley sign, polyhill sign to call it ST. And I also felt the hip abductors were stronger when compared to adductors, whether there was any hip abduction sign.
No hip abduction sign was there, sir, but as you said, the hip abductors were stronger than adductors, sir. So that favored more of LGMD, sir.
Pictures of
Megandan sir was about to say something. He came. Sir, Megandan sir.
I wanted to ask about sarcoclitus are like the drug. Whether do they have any role in this management? They give for hypertriglyceridemia like that.
அதான் bezafibrate போட்டாங்க. Anush or Satish, you can answer that.
Sir, bezafibrate didn't came positive, sir. The trial was not successful, sir. It was have a negative results only, sir. Bezafibrate. And regarding saroglitazar, sir, they have not tried any trials, sir. For they introduced for fatty liver initially the PPAR gamma inhibitor. They didn't try no trials we could have found with saroglitazar. They tried bezafibrate, which is negative, sir.
How about LDL in these patients? Is it abnormal?
Sir, LDL will be normal, sir. LDL, there won't be any abnormality.
Okay.
Sir, one more thing, sir. Regarding the targeted gene testing, sir, the initial steps are same for whole exome and genetic targeted testing, sir. So the price also doesn't vary much. So in order to don't want to miss any other mutations, we got her for whole exome, sir.
Vinod sir, you want to add anything?
I think, sir, this saroglitazar we have discussed, sir, but it was not been tried in that treatment aspect, sir, mainly. Mainly they have tried with the alternate fuel pathway, that's increasing the carbohydrate fuels, so that the lipid is not used as a fuel during the exercises or during any work or exercises. And mainly the patient can use as a carbohydrate source as a fuel for his energy. So the therapeutic managements mainly, they advise is mainly avoid lipid and use carbohydrate as a source of fuel for the maintenance treatment, actually.
Thank you for an excellent case. I do not know what Chengalpet team did. They also presented. I do not know the management. That was not discussed. Maybe I should ask Balaji.
I went as an examiner to Chengalpet Medical College, sir, this last 2 weeks back, actually. They told about these cases. We have discussed this, but I don't know what they have happened, but they have discussed a similar case we have also presented. They have told actually they must have.
Yeah, that's right. About 6 months ago, and they also the meeting also, the neuro update also they presented that case. There are 2 more cases. So if it's okay, CTS, can we go to the next case? Or
yes, sir. The second case is also by Dr. Anush. It's about the case is named as the triple threat. Over to you, Dr. Anush.
Thank you, sir. Now I'm proceeding with the second case, the triple threat. So, case history: a 28-year-old female following an acute febrile illness which lasted for 2 days, presented with unsteadiness, diminished vision on the left eye, double vision, and facial numbness of the face since last 2 weeks, preceded by a fever. Fever was a high grade associated with chills, rigors, fatigue, and myalgia. There is no localizing foci from the history, and there is no cough, cold, loose stool, swelling, ulcers, no headache, nuchal pain, or any altered sensory history. She herself took paracetamol for the fever, and it got subsided in 2 days, following which she developed acute onset neurological symptoms as mentioned. So first she noticed the unsteadiness, which is she is not able to stand, unsteadiness while standing and walking, which worsens in the dark and while washing the face. And there is severe intensity that she couldn't walk alone, and then she needed a support while walking. And there is no spillage of water and while attempting to drink, and there is no history of smearing of food around the mouth while eating, and there is no slurring of speech. And followed by unsteadiness. After 2 days, she has developed diminished vision in the left eye. She described her diminished vision as she is seeing through a thick fog, and colors appeared as less vibrant, and there is no distortion of the image, and there is no pain in moving the eyes, and there is no Utthav phenomenon or pause pains. Followed by decreased vision in the left eye. She also developed double vision, which is binocular and horizontal diplopia, without any diurnal variation, and which is worst for the far objects, and without any drooping of eyelids. And another complaint she told is the numbness of the face, which is bilateral, and it is a subjective feeling, though she was feeling the hot and cold water sensation as usual while washing the face, but she complained of numbness. She is able to chew well, and there is no lancerating pain. And the summary. A young female presenting with post-infectious sensory ataxia with multiple cranial nerve involvement, that is second in the form of diminished vision in the left eye, and bilateral fifth in the form of facial numbness, and sixth in the form of horizontal diplopia. Our probable diagnosis, first differential diagnosis was Query-Miller-Fisher syndrome, or other DDs are Tolosa syndrome, which the pain is missing in the history. And other differential diagnosis was sarcoidosis, because generally it usually chronic and systemic symptoms also will be present in sarcoidosis, along with the seventh cranial nerve involvement, which is missing in this case. So after the examination, general physical examination was unremarkable and patient was conscious oriented. Cognitive assessment was normal. Higher mental examination was normal. MOCA was 30/30. Cranial nerve examination. First cranial nerve was normal. She was able to smell. And the second cranial nerve, right visual acuity was 6/6. Left was decreased, that is 6/36. And fundus was bilateral. Disc margins were clear. And RAPD was present in the left eye, and the patient central field defects are more in the left eye. Right eye fields were full and normal. Third and fourth cranial nerve examination was normal on both sides, and fifth cranial nerve examination was normal on both sides. And bilateral sixth cranial nerve was pulse was noted in the form of patient was difficulty in abducting the eye in both the sides, and no other cranial nerve examination was normal. Motor, there is bulk, there is no significant asymmetry and no thinning or wasting noted. Tone, upper limb and lower limb tone examination was normal. And power examination, neck flexion and extension was normal. Shoulder power examination and elbow, wrist and other small muscles of hand power examination was completely normal. And lower limb examination also, power, hip and knee, everything was, ankle, everything was normal. Lower limb power examination also normal. In the reflexes, facial superficial reflexes was intact, and deep tendon reflexes, biceps, triceps, supinator, and knee were absent on both sides. Ankle was diminished on the right side, preserved in the left side. And the bilateral plantar was mute. This is the examination of reflexes.
Yeah.
The ankle also right side decreased, left side it was normal, sir. Sensory examination, proprioception vibration sense was impaired below knee, and the positive Ramberg test was positive, though the patient not able to stand with closed feet. Patient was able to stand with a little feet apart. At that time, Ramberg was positive. There is no dysarthria, no nystagmus. Bilateral finger nose test and hand chin test was normal, and there is no dysdiadokinesia. And there is no bradykinesia, tremors, rigidity, or any other involuntary movements. And there is no abnormality in the bedside autonomic function test. Spine and skull examination was normal. After examination, a young female presented with post-infectious sensory ataxia with multiple cranial nerve involvement in the form of left optic neuritis, bilateral sensory trigeminal neuropathy, with the bilateral abducens palsy. The patient was not able to abduction defect, and the patient was having areflexia with preservation of the left ankle zip. Our probable diagnosis was Miller-Fisher syndrome, which is a classical triad of areflexia, ataxia, and incomplete ophthalmoplegia. Then we proceeded with the blood investigations. There is routine blood investigations was normal. Viral serology was negative, and DNA profile also negative. Serum calcium and ACE levels were normal, and there is chest X-ray there is no hilar lymphadenopathy, and chest X-rays was also normal. Then we proceeded with the antibody panel. Then in view of Miller-Fisher syndrome, we suspected GQ1B positivity, but all antibody panel came to be negative. Electrophysiology studies, left median F was impersistent in the NCS, and right median F was almost absent. And the left ulnar F was impersistent. And right ulnar F was completely absent. Left tibial was absent and right tibial also absent. Upper level, lower limb CMAP and SNAPs were within normal limits. Then we proceeded with the VP. The left VP waveform was not obtained. Right VP latency was prolonged. Then we proceeded with the MRI brain. The first one is without contrast. Patient got it done outside, and this study was showing increased T2 signal in the left optic nerve. Second was done in our institute, which was after giving contrast. There is no much enhancement, no much differences after contrast enhancement. This has been taken after starting the treatment of day 2. Treatment and outcome: injection methyl prednisolone 1 gram IV OD given for 5 days. Now on follow-up and tapering dose of oral steroids. Patient improved and now able to walk independently. Visual acuity also improved to 6/24, and the patient is still having areflexia, but except for the preserved ankle jerk. This is on day 6 of admission. Eye ocular muscle examination was improved compared to the previous before admission. After giving 5 days of IV methyl prednisolone, she is able to abduct completely.
கீழே நேரா பாருங்க. பார்வை எப்படி இருக்கு இந்த கண்ணுல?
ஃபர்ஸ்டோட பரவாயில்ல.
பரவாயில்ல.
And she was able to walk normally after giving 5 days of steroids. About Miller-Fisher, Charles Miller-Fisher was a Canadian neurologist, first to describe transient ischemic attacks as a stroke precursors, elucidated the relationship between carotid artery stenosis and cerebral infarction, demonstrated atrial fibrillation as a major source of cerebral embolism. He contributed insights into lacunar strokes and their syndromes, cervical artery dissection, subarachnoid hemorrhage, and reversible cerebral vasospasm. His work advanced the use of anticoagulation in the stroke prevention and enabled surgical interventions such as carotid endarterectomy. He described numerous neurological signs and syndromes, including Miller-Fisher syndrome, transient global amnesia, ocular bobbing, and 1.5 syndrome, and the Fisher grade for subarachnoid hemorrhage severity. And the classical triad for Miller-Fisher syndrome was ophthalmoplegia, external eye movement weakness with often bilateral, ataxia, prominent gait and limb incoordination, areflexia, reduced absent deep tendon reflexes. The triad appears in most cases and defines the syndrome clinically. Predominantly cranial nerve involvement. Cranial nerve dysfunction is common, which presents with diplopia and ptosis. Facial nerve, some 30 to 50% of the cases presents with facial nerve palsy, and bulbar signs like dysarthria, dysphagia in severe cases. These reflect the high expression of gangliosides in the cranial nerve pathways. And anti-GQ1B IgG antibody association. Majority of the cases have anti-GQ1B IgG antibodies in serum, a highly specific biomarker. These ganglioside antibodies target oculomotor nerves and proprioceptive fibers and are central to diagnosis when present. Proceeding infection or immune trigger. MFS classically follows a respiratory or gastrointestinal infection like Campylobacter jejuni or Haemophilus influenza and viral agents, with onset of neurological signs up to 1 to 3 weeks later, supporting molecular mimicry and mechanisms. CSF and electrodiagnostics findings. CSF albumin-cytological dissociation, though may be absent in the early stages. NCS and EMG reduced or absent sensory responses and absent H reflexes, motor conduction often preserved early. And this help distinguish MFS from central process. Overlap with GBS spectrum disorders. MFS sits within the broader GBS spectrum and may overlap with sensory motor Guillain-Barré syndrome or Becker's of brainstem encephalitis or acute motor sensory axonal neuropathy, presentations occasionally with respiratory compromise. recognition of overlap impacts, monitoring and management. Atypical and variant presentations. Not all patients show the fully triad early or at all. Cases have been reported with isolated ophthalmoplegia without ataxia or areflexia, pupillary abnormalities, that is bilateral mydriasis, stroke-like symptoms like normal CSF, normal conduction studies initially. Awareness of these phenotypes prevent misdiagnosis. Management provides immunotherapy, IVIG, 0.4 gram per kg per day for 5 days in the first line. Plasmapheresis is an effective alternative. Corticosteroids are not recommended as monotherapy and may delay recovery. Early initiation based on clinical suspicion is favored without waiting for antibody confirmation. Supportive care with respiratory monitoring is crucial given rare but real risks of progression. Prognosis: most patients improve markedly with or without immunotherapy. Recovery typically over weeks to months, with the best functional outcome within 8 to 12 weeks. Case fatality is low, which is less than 5%, and recurrence are uncommon, which are less than 3%. New updates are novel treatments such as FcR inhibitors and complement modulators. Eculizumab are being explored but remain investigational. Expanded antibody profiling beyond anti-GQ1B, example anti-GT1A cross-reactivity, is emerging as relevant in atypical or autonomic presentations. These are the few journal publications which suggestive of optic neuritis may be the central nervous system feature that should be recognized as the part of Miller-Fisher syndrome. These are the few evidences that trigeminal nerve involvement also present, but it is rare in the Miller-Fisher syndrome. As this patient was complaining of facial numbness. These journals are suggestive of normal DTRs do not exclude Miller-Fisher syndrome, especially early in the disease or in atypical variants. Reflexes may be preserved initially, evolve later, or remain intact throughout. This phenomenon has been observed with both with and without anti-GQ1B antibodies. This video was taken after 2 weeks of treatment. When she was taking oral steroids, she came for review. Now the both angle reflexes were absent. Initially, left was preserved. Now both came to be diminished. Although most guidance states steroids are not recommended for classic Miller-Fisher syndrome and may even delay recovery in GBS or MFS, the below case report suggestive potential roles of corticosteroids in Guillain-Barré syndrome, MFS variant. Anti-GQ1B positive in 80 to 90% of the classic MFS cases. Therefore, 10 to 20% of the patients can be anti-GQ1B negative. This is one of those cases, and MFS remains a clinical diagnosis, and antibody negativity does not exclude it. These are a few publications suggestive of antibody negativity in MFS. In the conclusion, MFS is an anti-GQ1B cranial neuropathy with proprioceptive ataxia. Atypical features in our patient was optic nerve involvement and trigeminal nerve involvement, which she has a complaint of facial numbness, preserved ankle jerk with anti-GQ1B negativity. And patient was responded well to the corticosteroid therapy. IVIG or plasma exchange is considered as standard. The patient responded with corticosteroid therapy, pulse steroid therapy. Thank you.
Was the NMO or MOG done?
Sir, it came to be negative, sir. Yes, sir. Yes, sir. Yes, sir. It came to be negative, sir.
Okay. Yes, sir. There are too many atypicalities for me to agree with the MFS. Let's see how many of others agree to that. Allegation, CTS, Megandan, there are so many people there. I wouldn't label it straight away as MFS because, as you pointed out, there are 4 atypical features: eye involvement, trigeminal involvement, and absolutely dramatic recovery with steroids, all these, I am not concerned very much about anti-GQ only. That's okay. Or not the preserved anchor jack. But the other three certainly doesn't fit in. Let's see what others have to say.
Further case reports of optic nerve involvement, trigeminal nerve involvement in MFS.
Yeah, I agree with you. There are case reports.
No, sir. Only
that wouldn't be our first diagnosis.
No, I'm asking both together, sir. Because optic nerve with MFS has been reported. Trigeminal sensory neuropathy with MFS has been reported. I want to know whether both together has been reported.
And also, the dramatic improvement. See, 6th day she was normal. Sir, that doesn't happen with the classical MFS.
So that we see, sir, they actually respond very well to steroids, sir. Even I have seen 2-3 patients, sir, for Miller-Fisher partial MFS, sir, actually.
Yeah, the CTS,
yes, sir, yes, sir. Sir, over 1 week, MFS patients, they do really well, sir. Some group of patients.
Miller-Fisher is purely peripheral, sir. MFS so far described is purely peripheral. But here, patient has got both central as well as peripheral.
Continue.
Symptoms developed following a febrile episode. So good response to steroid. Everything fitting with Mogard. The second possibility I will think of, if the Mogard antibody is negative, probably we can think of anti-neurophasin antibody disease also possible, sir.
Anti-neurophasin allegation இவ்வளவு நல்ல ரெஸ்பான்ஸ் இருக்குமா? உடனே இவ்வளவு குயிக் ரெஸ்பான்ஸ் இருக்குமா?
MRI brain was done.
Normal, sir.
Yes.
Normal.
Except the optic nerve awareness.
You have done VEP for this case, and VEP was done, and was it delayed?
Yes, sir.
Both sides. Bilateral delay.
What was the visual disturbance like? Acuity was affected. What about the color vision?
Sir, color desaturation was present, sir, and she was telling like she was seeing through a fog.
Hazy vision.
I don't understand, because that is the only thing which is very tricky here. Because second involvement we have never seen. Miller-Fisher, again, as Professor pointed out, that recovery is so fast. We have struggled with patients with MMS. We have a steroid not responding. We have struggled. But Miller-Fisher is something which is with second involvement, though it is reported. What is the differential diagnosis they have given in the reference?
The primary demyelinating diseases like multiple sclerosis and MOG and NMO, sir. These are all the usual differentials, sir. We also had this differential, sir.
Satish.
Yes, sir.
Post-infective demyelinating disorder.
Yes, sir.
Enna, we don't know. Nothing fits. Just post-infective demyelinating disorder.
Yes, sir. Yes, sir.
CSF enna சொன்னீங்க?
Sir, CSF, he was not willing, sir, actually.
Something again missing. Okay. Could have been contributory. Could have been.
Yes, sir. Could have, sir. And all Fs were absent, sir. That was somewhat odd feature, sir. All Fs were absent. But CMAP and
proximal motor nerve involvement was there. Sensory potentials were absent.
Snap normal, sir. Snaps normal, sir.
Again, another atypical feature. Usually, as he pointed out, snaps are absent in Miller-Fisher. So what I'm saying is we don't give a label. We'll just say post-infective demyelinating disorder.
Yes, sir. Yes.
But what label? I don't know what we could give.
More likely label, sir.
என்ன allegation, CTS, நீங்களா சொல்லுங்க.
The more likely label could be MFS.
யார் சொல்றா?
Suresh, sir, CTS.
MFS somehow I am not able to accept.
Sir, more likely na.
It's very
allegation சொன்ன மாதிரி why not
Miller-Fisher, sir.
Why not Mogad as allegation says with an optic nerve involvement? We don't know. Nothing fits.
So whether the bilateral sixth nerve was maneuverable, not maneuverable?
Anush தான் சொல்லணும்.
Dr. Anush,
Sir.
whether the bilateral sixth nerve was, was it maneuverable, not maneuverable on examination? And how was Romberg's treatment? Romberg's fine.
Sir, Romberg's, it was positive, sir. Actually, initially she was not able to stand without support, sir. But through legs wide apart, she was able to stand, sir. At that time, Romberg's was positive, sir.
Positive.
And the patient was having bilateral abduction weakness, sir. She is not able to do abduction properly, sir. Gaze, left to the right side gaze is affected more, sir.
டால்சைல என்ன ஆச்சுப்பா?
Horizontal gaze is affected.
மெனூவரபிள்னா டால்சைல என்ன ஆச்சு? ரிஃப்ளெக்ஸ் ஐ மூவ்மெண்ட்ல ஏதாவது சேஞ்ச் இருந்ததா? டால்சைல சேஞ்ச் இருந்ததா?
No, sir. No, sir. No, sir. No, sir. No, sir.
It was a history of diplopia. Diplopia?
Horizontal diplopia, sir, which is binocular, sir.
Vinod, instead of pushing into a diagnosis with so many atypicalities, why not we leave it open? Just say
what are the findings we have picked up is fitting into MFS, sir, clinically. She has presented with
நிறைய finding fit ஆலையேப்பா.
ஆமாம் sir. She has an optic neuritis, vision disturbances with the diplopia, along with ataxia, along with reflexes lot, except that ankle jerk was present previously.
And a trigeminal nerve. And a trigeminal nerve.
Trigeminal nerve, predominantly a subjective involvement only, sir. It is not an objective involvement. Subjective, she told us some numbness is there on the face. So clinically, we fit into MFS. We have come across cases with the MFS, sir, which has responded dramatically to steroids. I have 2 to 3 cases which has not also responded to steroids. I have some cases with responding to steroids beautifully for within 5 days, sir, actually. So our provisional clinical diagnosis was MFS, sir. So some of the atypical findings we have thought of that it may be due to MFS variants. But as you told,
snaps are present.
Yeah. Yes, sir. And there are some more switches are there, sir.
So this is MFS plus
clinical syndrome. Yes, sir.
MFS plus syndrome.
Combined central peripheral demyelination. So we have only 3 options, sir. Mogad, Adam, and anti-neuroficin antibody disease.
மோகாடுக்கு அடுத்து என்ன சொன்னீங்க அழகேசன்?
Neuroficin antibodies.
Anti-neuroficin antibodies.
ரெண்டு நியூரோஃபேசினுக்கும் மோகாடுக்கும் நடுவுல ஒன்னு சொன்னீங்களே.
Adam.
MRI negative Adam.
MRI would have been helpful.
இது எதுலயுமே ஃபிட் ஆகல. We don't know. That's all. I see. We have a large number of cases where God only knows or I don't know. அந்த கேட்டகரியில தான் போகுது. என்ன பொறுத்த மட்டும். Of course, if you want to push in, you can push in. But I don't know. What's the point in pushing in something which is not certain? Why don't you leave it as post-infective demyelination? Primary, it's a post-infective demyelinating disorder. அப்படியே விட்டா என்ன தப்பு? என்ன சதீஷ் and Vinod?
Yes, sir.
Yes, maybe, sir.
Okay.
CTS, your comments, and then we can move on to the third case.
A wonderful case, sir. I'm enthralled by this.
See, many a time the cases which are presented,
this is a nice case, sir.
We don't have answers.
This can be
excellent cases. இது கொஞ்சம் genetic study பண்ணுமா? To throw up something. Invariably geneticsல தான் ஏதாவது ஒண்ணு மாட்டுது. என்ன serious third case ah?
Yes, sir.
Yes, sir.
Dr. Sharat Kumar, sir.
Thank you.
Thank you for both the cases, Anush. Thank you very much.
Thank you so much.
Yeah, educative cases parla. Thank you.
Thank you, sir.
Dr. Sharat, please.
Now again starting trouble. Huh? Are we on the line?
Yes, sir, we are online.
Yes, sir. He's joining now, sir.
Okay.
He's already in the meeting only, sir. He's sharing, sir. Yes.
Before he starts, what was the triple threat in the previous case?
Unsteadiness, optic neuritis, numbness of face. Actually, the four threats, sir. Actually, they could have added the sixth nerve also, I think.
That's threat.
The four threats.
Are these threats?
அவங்க அந்த மாதிரி ஹெட்டிங் கொடுத்திருந்தாங்க சார். இட் வாஸ் வெரி அட்ராக்டிவ்.
இல்ல அவங்க சொல்லட்டும் என்ன why they gave that heading. என்னப்பா அனுஷ்?
We only choose, sir. We want to give a specific name for that. It was so much was attractive to the topic, so that we choose that, sir.
Okay.
Four threats, sir. Actually, they should have added.
Yeah. Quadruple threats.
Appa, 4 symptoms, appa. Why do you call them as threats?
Cis now is part of the Miller Fisher, Anna.
These are all
Yes, sir.
AI-mediated topic discussions.
Okay. I just want to know what was threatening there.
The next case is diagnosis we came to know, but it was therapeutically we was struggled by treating the patients. There was a unique mode of presenting this case. And therapeutically we have struggled on which drugs to choose. We have struggled in choosing the drugs. But anyhow, the patient has been surveyed with the treatment.
Go ahead. Thank you. That again will be educative. Go ahead. Full screen வரல. இன்னும் ஸ்லைட் ஷேர்ல தான் இருக்கு. Yeah, correct.
Audio is missing, sir.
Saran Kumar, your audio is not audible. You are not audible. Only your slides are moving.
Sharath, you have to unmute.
Am I audible?
Yes.
So I'm not able to share full screen share.
Okay.
Just like proceed with this. I'm not able to put it in full screen. Can I proceed, sir?
Go ahead.
Sir. 12-year male from Arakonam, Tamil Nadu. Was informed of his mother. His reliability was good. Presented with chief complaints of fever for 4 days, complaints of vomiting for 2 days, complaints of involuntary movements of all 4 limbs associated with uploading of eyes. History of presenting illness. Child was apparently normal 4 days back, after which he developed complaints of fever, which was high grade, intermittent, relieved on taking medication. Complaints of vomiting for 2 days, which was non-projectile vomitus containing food particle, non-blood or bile stain, and complaints of one episode of involuntary movements of all 4 limbs, which was lasting for 2 minutes, associated with uploading of eyes and drooling of saliva, followed by post-ictal confusion. Initially, child was taken to outside private hospital where he was treated with IV medication like injection amikacin and Levipil and referred to our institute in view of altered sensorium. Child had no history of recent travel and patient had normal antenatal, natal, developmental history and vaccination up to date and no significant past or family history. Course in
Can you
ICU
bring
on
the
day 1.
slideshow, please? Slideshow.
அதான் போக முடியலையா?
Not able to put it in full screen. Course in ICU on day 1. On receiving ER, child was disoriented. GCS was 9/15. Pupils bilaterally equally reacting to light, which is 3 mm. Vitals were stable. There were no signs of meningeal irritation. In view of low GCS, child was intubated. Anti-epileptic therapy was started with injection levetiracetam. Then empirical treatment for suspected meningitis was initiated with injection ceftriaxone, acyclovir, and vancomycin, along with anti-edema. Sedation was maintained with injection midazolam and fentanyl. Routine investigation and fever profile were within normal limits on arrival. Then CT brain was done. It showed no significant intracranial abnormality. On day 2, in view of fever with altered sensorium, tropical fever associated encephalitis was suspected, and thus dexamethasone was started and tablet azithromycin was started. Further, the child had 4 episodes of GTCS, which was aborted with injection midazolam. Then we'll proceeded for lumbar puncture, which reveals CSF glucose of 50 mg per deciliter, protein of 85 mg per deciliter, AD of 1.8, and total cells of 31, and culture showed no growth. Then CSF meningeal encephalitis panel, including biofire, was sent. Then injection levetiracetam dose was increased to 60 mg per kg per day. Then we have sent blood and urine culture, showed no growth. Then EEG suggestive of generalized epileptiform activity with diffuse flowing, frequency of 3 to 4x. Then fitting into non-convulsive status. On day 3, MRI was done, showed normal study. In view of recurrent seizure, additional AED were initiated subsequently. Injection with injection lacosamide, injection phosphonatide, taflobas were added. Then CSF viral panel came negative. Then repeat EEG done, showed delta brush pattern, suggestive of autoimmune encephalitis. Initially, we suspected of autoimmune encephalitis. We started on injection methylprednisolone, 30 gram per kg per day. Then patient had 2 more episodes of GTCs, then aborted with midazolam. This EEG showed delta brush pattern initially. Then we suspecting autoimmune encephalitis, we started on injection methylprednisolone. On day 4, the child had 9 more episodes of GTCS, then aborted with midazolam bolus, and later infusion was started at 8 microgram per kg. Then injection sodium valproate was added at 40 mg per kg body weight. Then lamotrigine was started. On day 5, in view of refractory seizure, we started on infusion with ketamine and midazolam. On day 6, patient was persistently throat seizure. Then we add injection thiopental in thiopental. Then tablet topiramate was added. On day 4, the child remained seizure-free for 24 hours, following which sedation was tapered. Subsequently, the child developed fever spike of more than 101. CRP was also elevated, and the antibiotics were escalated to injection meropenem. Urine routine showed yeast growth, for which fluconazole was initiated. Then on day 8, after gradually tapering injection midazolam, the child developed 11 episodes of JTCS, following which IVIG was started at 0.4 gram per kg for 5 days. Then patient had persistent fever spike with elevated CRP. Then child had two more episodes of GTCS. Infusion thiopental increased to 2 mg per kg. On day 9, sedation was deepened to achieve burst suppression. EEG showed early suppression of the epileptic burst. Initiation of intrathecal dexamethasone for 4 days was given in view of suspected fires, febrile infection, refractory epileptic status. Then added tablet paramphenol. Noradrenaline infusion was started at 0.04 microgram per kg in view of hypotension. Child initially. This is the initial status of the child, showing subtle seizure despite of multiple AEDs. And EEG suggestive of epileptic burst. On day 10, autoimmune panel confirmed NMDA receptor encephalitis. Then ET culture grew acetobacter pneumoniae. Antibiotics were modified to tablet septan and injection doxycycline. Sedation level deepened in view of epileptic burst. On day 11, whole body CT was done to rule out any paraneoplastic syndrome, which was normal. The patient had dyskinetic movement. EEG again showed adequate burst suppression. Then we added on, we started on ketogenic diet. On day 12, IL-6 levels reported normal. CSF culture showed MRSA growth. And day 13, EEG showed adequate burst suppression. Then child underwent tracheostomy in view of prolonged intubation. Post-operative period was uneventful. ET culture showed acetobacter pneumoniae. We started on injection colchicine. Then repeat EEG showed adequate burst suppression. On day 14, the child developed hyponatremia with polyuria, elevated urine osmolality, and low serum osmolality, suggestive of cerebral salt wasting syndrome. As per our nephrologist opinion, we started on tablet fluorocortisone and salt supplementation. Then tablet zonisamide was started in view of continuous EEG discharges on weaning general anesthetic agents. Then again, repeated EEG showed a non-convulsive status of epilepticus pattern. Then day 15 to 17, EEG showed continuous NSCAC pattern in view of persistent seizure, initiated on syrup cannabidiol 2.5 milligram per kg per day. Then started on sulbactam in view of ventilator-associated pneumonia. Then colchicine was stopped and polymyxin was initiated in view of oliguric AKI, which is probably due to colchicine-induced. Then injection phenobarbital was started, general anesthetic agent started, and sedation deepened to achieve burst suppression again. On day 18, continued injection polymyxin B at 15,000 international unit per kg for 48 hours. Then switched to minocycline. due to non-algorithmic AKI, continue to have multiple episodes of seizure in the form of oral twitching, eyelid twitching, and tonic-clonic movements of hands and feet. Then phenobarbital dose was increased to 10 milligram per kg per day. Then cannabidiol dose increased to 10 milligram per kg per day. Then day 23, plasma exchange was started in view of refractory seizure. Patient developed metabolic alkalosis following post plasma exchange. Then lower limb Doppler showed DVT extended in right common femoral vein. Then EEG showed seizure activity on reducing anesthetic agent. In discharge of 1.2 hertz increasing to 3 to 4 hertz with background delta activity. Repeat culture again showed Acetobacter baumannii. Then day 18, plasma exchange was completed. Then we started on injection rituximab as infusion of 375 milligram per meter square per day. Since the patient did not had fever spikes for 48 hours, then again we repeated EEG showed epileptiform discharges. Then day 42, second dose rituximab was given. Child clinically improving. EEG was much better. Then child had dyskinetic movements. General anesthetic agents were gradually weaned off. On day 50, general anesthetic agents were completely tapered off. Patient had occasional dyskinetic movements persisted. Now, current status at present, child is on injection dexamethasone 8 mg IV OD. Now, child is off ventilator. No cognitive impairment. Clinically much better. But patient has 1 to 2 episodes of seizure every alternative days, but the child is normal between the episode. Patient currently on levetiracetam, sodium valproate, lamotrigine, lacosamide, carbapenem, topiramate, zonisamide, phenobarbital, all are in near maximal doses, and cannabidiol. Now, patient current status. Coming to diagnosis, NORS, new onset refractory status epilepticus with anti-NMDA receptor antibody positive autoimmune encephalitis, super refractory status epilepticus with persistent non-convulsive status epilepticus, then cerebral salt wasting syndrome and ventilator associated pneumonia. Coming to status epilepticus definition, define a seizure lasting 5 minutes or longer, a recurrent seizure without recovery of consciousness between. According to International League Against Epilepsy, defines T1 and T2. T1, which is time beyond which if seizure persists, patient persists, and T2, time after which persistent seizure have long-term consequences. Usually T2 mostly do not resolve on its own. It will persist to more than 30 minutes. In general convulsive status epilepticus, in focal status with impaired consciousness, more than seizure persists for more than 60 minutes. Then coming to types of status epilepticus: convulsive, non-convulsive, neonatal, myoclonic, epilepsia partialis continua. Then coming to refractory status epilepticus, the status epilepticus which seizure failed to resolve despite therapy with benzodiazepine and diazepine and non-benzodiazepine medication. And super refractory status epilepticus status that has failed to resolve or reclose within 24 hours or more despite therapy that with a continuous infusion. NORS, new onset refractory status epilepticus, is a clinical presentation in patient without active epilepsy or any pre-existing relevant neurological disorder with new onset refractory status without a clear acute active structural toxic or metabolic cause. Fires, febrile infection related epileptic syndrome is a subcategory of NORS that requires a prior febrile infection with fever starting between 2 weeks and 24 hours prior to onset of refractory status epilepticus, without or with fever at onset, usually the onset of 2 to 17 years of age, which was characterized by increased CSF or serum IL-6 and IL-1 levels. Coming to NOS classification with identifiable cause like infection or neurometabolic, then autoimmune cause, then cryptogenic NOS. In coming to NOS workup, Initially, patients had history of any immunosuppression, vaccination, febrile illness, travel history, or animal exposure. Then focused evaluation with history concerning for autoimmune encephalitis. Then with serologic or imaging to evaluate evaluate the cause. Then with metabolic or identifiable risk factors. Then will then coming to neurological examination, focused investigation based on the history. Then imaging MRI brain, MRA with continuous EEG monitoring. Then serum and CSF analysis to look for any HSV encephalitis. Then if we found any etiology, then we'll go for serologic or imaging evaluation. Then we'll go for first immunosuppressive agents like corticosteroid like methylprednisolone. Then we'll proceed for IVIG. Then we'll proceed for plasma exchange. No response, we'll go for monoclonal antibody rituximab, tocilizumab, anakinra, and ketogenic diet and cyclophosphamide. Then international consensus and recommendation for management of new onset refractory seizure suggestive of rituximab, plasma exchange, and initiation of methylprednisolone. Then coming to NOS workup initially within 45 minutes of diagnosis, we have to rule out for comprehensive rheumatologic evaluation. Then comprehensive infectious evaluation including culture, viral, bacterial serology relevant in geographical region and season. Then evaluation of in-brain errors of metabolism in young children. Then autoimmune and onconeural antibody panels. Then extra blood samples for storage of future analysis like cytokine and genetic analysis. NOS workup in CSF, comprehensive infectious evaluation relevant to the geographical region and season. Then evaluation for in-brain errors of metabolism in young children like lactate, pyruvate, and amino acid abnormality. Then we'll go for autoimmune antibody panels. Management according to consensus guidelines. The first line immunotherapy should be started during the first 72 hours. Then we'll proceed for IVIG, and steroid can be administered simultaneously. Then ketogenic diet to be added in the first week. Then differences in cryptogenic NOS and NOS with established etiology. High seizure burden in cryptogenic NOS, lower in NOS with established etiology. In cryptogenic NOS, cognitive dysfunction is more than NOS with established etiology. Prodromal favorably more in cryptogenic NOS than NOS with established etiology. Then symmetric abnormal MRI abnormality is more in cryptogenic NOS, and absent psychosocial behavioral in cryptogenic NOS. Psychogenic behavioral symptoms present in NOS with established etiology. Then continue workup for the NOS. In suspicion of paraneoplastic encephalitis, whole body CT or PET scan can be done. In suspicion of mitochondrial disorder, MR spectroscopy, genetic testing, ammonia, plasma, and CSF lactate can be done. In suspicion of genetic disorder, whole exam sequencing. Then immunocompromised patient, PCR can be done. Then management of initial status epilepticus at arrival between 0 to 5 minutes. We'll check airway, breathing, circulation. Then we'll perform routine investigation. We start on LORAS 0.1 mg per kg, then MIDAS and diazepam. In season persistent for more than 5 to 10 minutes, we have to watch for raised ICP pressure. Then we'll add phenytoin or phosphenytoin. Can increase phenytoin levels or phosphenytoin level up to 10 milligram per kg. Then seizure persists for more than 30 to 60 minutes. Watch for raised ICP, sepsis, cardiac arrhythmias, and monitor organ function. Can add valproate, sodium phenobarbital, levetiracetam. Start maintenance dose after 8 to 12 hours. Then management of refractory status epilepticus. General anesthetic to achieve burst suppression. Injection midazolam, bolus followed by infusion at 1 microgram can be started. For every 5 to 10 minutes, still seizure persists, stop. Then high dose phenobarbital, 5 to 10 milligram per kg bolus can be added for every 30 minutes. Up to 120 milligram per kg over 24 hours can be maintenance can be given. Then propofol loading dose 1 to 2 milligram per kg followed by continuous infusion. Then thiopental loading dose 5 mg per kg bolus followed by 1 to 5 milligram per kg for infusion rate. Then coming to management of super refractory status epilepticus, ketogenic diet can be added. The diet should contain carb of 5 to 10%, protein of 20 to 25%, fat of 70 to 80%. We can go for immunotherapy, then vagal nerve stimulation, then epilepsy surgery like resective surgery in the focal resection, then laser interstitial thermal therapy, then corpus calostomy, then ketamine infusion can be added, then inhaled anesthetics. Then final goal to reduce seizure risk. The goal is to achieve electrographic seizure by reducing the therapy, done by achieving complete flattening of EEG by burst operation. Take-home points: to start immunotherapy yearly in cases of suspected autoimmune or cryptogenic loss. To escalate yearly, the patient is not responding to first-line AED or immunotherapy. Good ICU care can do wonders, as documented in this patient. Never give up in the face of storm. Thank you.
We must congratulate the teams because the child is still alive, you said. No? The child had so much severe status epilepticus and super refractory status epilepticus, and you have definitely managed somehow. Most of the time we lose the children. And it is NMDA positive, isn't it?
Yes, sir.
Yes, sir.
And the abdominal scan, you said the PET scan you have done. No, it was
No, not PET scan. Whole body CT we have done. All CT we have done, which was normal only, sir. Not PET.
But initially you said that autoimmune encephalitis was diagnosed with EEG. MRI was normal, absolutely, isn't it?
Yes, sir, normal.
Did you repeat MRI? Did you repeat CT brain at least?
Yes, sir. MRI was repeated like after 3 weeks or so, so to look for any other new abnormalities. It was normal again, sir.
That is the only thing which is very clinching. Did you take sort of any zooming picture, sort of any other area, sort of limbic area? Nothing was seen. Any signal change?
No, sir. MRI was normal.
3 Tesla? Was it 3 Tesla, 1.5 Tesla? Because NMD encephalitis we have diagnosed, of course, it is antibody positive, but initially. And again, once you have diagnosed, you could have straight away gone for rituximab, sort of instead of going for sort of delaying for with plasma exchange and all those things.
The rituximab takes about 2 to 3 weeks to act, no, sir. So we wanted the immediate response because child was continuously seizing, sir. We also started rituximab simultaneously with plasma exchange, sir. Plasma exchange was going on. We started rituximab. Post the sessions, we gave rituximab first dose, sir. Like third cycle of plasma exchange was going on. We started simultaneously only, sir.
Oh.
Dr. Sharat Kumar.
Yes, sir.
Only thing which I would like to add to your take-home points,
yes, sir,
is early institution of anesthetic agents.
Oh, okay.
That is what is, see, nausea, once we suspect nausea,
yes, sir,
most often they require anesthetic agent to suppress the seizures. And of course, rest of the things, as you pointed out, immunotherapy and other things, yes. But probably early institution of anesthetic agent would reduce the difficulties you face with.
Yes, sir.
Yeah, as Megadans has said, you have done a remarkable job, a heroic job. It's the problem is with instituting so many anticonvulsants, and then it adds on with the other comorbidities also, like infections and other things on top of it. So basically, even if it is NMDAR, it's only immunotherapy with cessation of convulsions. That's what we need to target. Yes, sir.
So in super refractory status, the latest article recommending we have to initiate ketamine earlier, sir.
Yeah, amongst the anesthetic agent, ketamine is now At present, ketamine is propagated more and considered to be the first line.
And
Yes.
particularly this NMD receptor and encephalitis, it is more beneficial. That was the literature says, because it blocks the NMD receptor also.
Oh.
And also in patients with ICT, ketamine is very useful.
Yes, sir.
We have used ketamine also. It was not very useful. As you said, that inhalation anesthetic agent,
Yes, sir.
that is more effective than this ketamine business. Ketamine, propofol, we have faced several problems with propofol.
Ketamine in this case?
We are given, sir. Yes, sir.
Ketamine has been given, but as it is pointed out that ketamine also is not working, sir, NMDA. Though it is said that it is a very good drug, but it is not very useful. But anesthetic, you anesthetize him completely. That is only way by which you can.
Yes, sir.
Now, how frequent is autoimmune encephalitis presenting as fires?
Yeah, initially we never diagnosed autoimmune encephalitis. This patient we would not have diagnosed because we would have thought it is only viral encephalitis, and of course only when the antibody, because autoimmune encephalitis is little slow progressions. Initially they start with a sort of cognitive impairment, childhood
3 months.
impairment, behavior. Yeah, initial. Then only we start. They most of the time we get a history like that.
That is the most interesting thing in this case. Autoimmune.
Yeah, here it just started as encephalitis and became anti-autoimmune encephalitis.
CTS,
Yes, sir.
in any new onset refractory status, we have to start immunotherapy.
Yes, sir.
Till we wait for results, we have to start immunotherapy, anti-seizure medication, if required, anesthetic agents. These are the key agents which are going to be helpful.
So the newer articles, they are recommending tocilizumab for fires and NARS. Any experience from anybody else?
Sir, actually, we wanted to start tocilizumab in this patient, sir. So initially, we have intrathecal dexamethasone, which is also recommended for fires, sir. But the IL-6 levels turned out to be normal, sir. So by that time, we had the results of the autoimmune profile. NMDR came out positive. So we went in the line of rituximab rather than tocilizumab, sir. The initial plan was to go tocilizumab only, sir.
Rituximab response is excellent, sir. Usually. The second dose you give, the patient recovers. And we have never gone for the next tocilizumab. Yeah.
Sir, I have a question for the forum, sir, if you may ask, sir. So this patient, even though he's clinically better now, he's conscious, he's obeying everything, he's still having seizures like every other day. Yesterday also he had 4 to 5 episodes. He's still there in our ward, but he's having seizures on and off, sir.
He will continue to have.
Yeah,
that's going
you
to
have
be
to reduce
long
the
time.
anticonvulsants. Reduce the anticonvulsants. Take minimum anticonvulsants, and use midazolam spray like that on and off. And they are going to have sort of convulsions for several years.
One-fifth of the patients will have they are seizure refractory. You have to put them on multiple anticonvulsants.
IVIG போட்டோமா அந்த பேஷண்ட்டுக்கு?
Yes, sir. IVIG also.
Oh, okay.
Sir, how long will we continue immunosuppression with steroids in this patient, sir? Because he's already on steroids, dexamethasone. Rituximab is already going on. Rituximab is second dose completed. So is there a role for continuation of steroids beyond this period, or we can taper the steroids and?
No steroids. Not necessary. Anticonvulsants and supportive measures. That's all. And again, sir, IVIG, plasma exchange, all those regime, we are following. We personally felt that all those things they look like a sort of. So we have just given for the sake of completion, because their response starts only when the patient starts getting rituximab. It's only a cytokine which makes the major problem rather than the antigen antibody. IVIG and with plasma exchange, they do not help much, or they do not add to the treatment also. I don't know. A stage may come that people may, once you diagnose autoimmune, they may straight away go for MABs and NIBs like that. I think a stage may come like that. Your IVIG and plasma exchange, all those things may slowly will wean off. Once as he said that other MABs will come, I think. More and more specific. Rituximab still holds good.
Thank you, sir. Once again, thank you very much for an illustrative, educative case again regarding management. Thank you, Sharath.
Thank you, sir. Thank you so much. Sir. Thank you for this opportunity.
Yeah. Thank you, Vinod, for all those excellent cases.
Thank you so much, sir.
Savita team, and of course, CTS.
Thank you, sir.
Very much, and all the discussants, and the Sun team as usual. Thank you. Anything else you want to add?
Sir, anybody wants to see the book Brain on Fire, Susanna Chahalan book? I'll just show the book.
Okay.
Brain on
Fire. Can you get this? Shall I go for it? The book is on my table.
You'll have to project it. Yes, sir. Can see that.
Yes, sir.
You'll have to maximize. You'll have to maximize, sir.
Yeah, you can see that. It's a beautiful book, sir. The lady who was written has suffered from the illness, and she has recovered, sir. That is very interesting. And she herself feels how was it like when she started getting, how she was able to see another Susanna outside. It's very interesting.
Thank you, sir. Thank you, sir.
Thank you, sir.
There's one question, I think. What is that? Chat box leather. Okay. Hold on only. Okay. Thank you.
Thank you, sir.
Thank you.
Thank you, sir. From our side, thank you, Vian, sir, for giving us this
thank
opportunity.
you. We'll get to see more cases from your side.
Yeah, sure.
Thank you, Savita team.
Yes, sir.
We are ready all the time, sir. We can tell you, we can ready to present at any time, sir. Thank you so much, sir.
Suresh, when is your team ready?
So we are ready in April, sir.
2-3 months? Yes. Okay. Thank you. Alagasan, sir, thank you.
Thank you, sir. Thank you.
Thank you, Mangana, sir. Alagasan,
Thank you so much.
Thank you. Kani, can we leave?
Yes, sir, you can, sir. Thank you, sir.
Thank you, Pa. Thank you so much for arranging everything.
Sure, sir. Thank you, sir. Welcome, sir.
Welcome.
Yes.
We finished on time.
Yes, sir.
So it was excellent session, sir.